Excuse me. All right, you ready?
Yep.
Okay. All right, so today we're going to highlight basic adult cardiac arrest management to include the pit crew procedure we use, and we'll move on to transition to Lucas device and show you guys what that looks like too. So for our scenario, we're working with an adult patient. We'll be working on the standard AHA guidelines for cardiac arrest management, and then we'll show you how it's done also in our system using the pit crew. So we're going to start with those three procedures, and without further ado, we'll get going. Of course, we already know I've got my BSI in place. The scene is safe. We're at our fire station. We've established that. We have one patient that's what we'll be working on, and from here we'll be moving into the call. You guys ready? All right. So I'm coming in. I've got a patient here that appears to be in distress. This is reported as a man down, already man down, and sure enough, we're here, and we find out that he is not breathing. We look at him. He looks kind of pale and cold. He's sitting up in his chair, and there's no witnesses, so this is an unwitnessed arrest. He just encountered it in a nursing home, sitting in the lounge. I'm going to go in for a pulse check, and since this is a adult patient, it's potentially in cardiac arrest but is unconscious, the pulse check is going to be at the carotid. I'm going to do a quick pulse check here and determine that the patient has no pulse. I do not see any chest movement. He's not breathing, so he's going to be a good candidate for adult cardiac arrest procedure. So guys, if you get your help from you, he's not going to be able to do this procedure in the chair because where he's laying right now, we don't have enough stability behind him to do compression, so we're going to move him out. One quick move. You got the head. Your count. 1, 2, 3. All right, we're going to the floor. Once we get the patient to the floor, we're going to start into our CPR procedure. There's 3 of us here to start. I'm your initial person doing compressions. We've already established he's going to need those. So I'm going to find my hand position, maybe at the chest, and I'm going to start with my compressions. I'll count to 100. Our compressor number 2 is right behind me doing the compressions. He's going to be the AED procedure. We're doing this in real time. We're also slowing down to show you guys how this works. So I'm going to go ahead and start. I want to do at least 2 inches depth. My compressions no more than 6 centimeters. And I'm going to do 100 compressions as they get the rest of our equipment set up. 1, 3, 6, 7. And I'm moving my hands off the chest just to accommodate get the shirt off. About 50. Not yet. We're going to give it a full 2 minutes. Go ahead and turn that off. Air's off. 81, 82, 83, 84, 85, 86, 87, 88, 89, 90, 91, 94, 95, 96, 97, 98, 99, 100, 2, 3, 4, 5, 6, 7, 8, 9, 10. For the sake of time, we're going to accelerate this up a little bit. We're doing 2 full minutes first. I'm going to go off the chest and talk to you guys for a second. We would continue compressions at this time. The reason we're not shocking this patient right off the bat is because this is an unwitnessed arrest. All his blood is pulled to gravity-dependent areas. All his blood is in his back, his legs, lower extremities. And because of that, we want to circulate the blood first through the body before we apply a shock. If we apply a shock to the heart and we try and restore a rhythm, there's not any blood to be circulated, it's not going to have a perfusing beat when we're done with it. So at this point, we're going to say I'm going to come off the chest, and I will have done 100 compressions, 98, 99, 100. He's going to analyze. And anytime that's not moving, not analyzing, we're going to keep compressions in place.
Stand clear.
At this point, stand clear. He will take over compressions from me next.
Stand clear. Shock advised.
Okay. I'm clear. You're clear. We're all clear. Clear. You'll be hitting the shock button. Boom. Right back into compressions. Compressor number 2 will assume compressions. Compressor number 1 will move back out of position and be ready to move back in after 2 minutes. In the meantime, our airway guy is going to apply a non-rebreathing mask. We're going to get some adjuncts for him too. Since the patient's unconscious, he's going to get an OPA. So if you'll grab me an OPA. The reason we want to do the non-rebreather first and not move to a BVM directly, this is a basic airway. This airway is not protected. When we put oxygen or air down the airway, it's going to be indiscriminate. It's going to go both into the esophagus and it's going to the trachea where we want it to go. Airway going to the esophagus is going to go in the stomach. It's going to cause the stomach to get bigger. What it does is push the stomach and the contents and everything up, moves the diaphragm up, which gives you less room for the heart to work and to be able to take in blood and have a good cardiac return. It also keeps the lungs from being able to inflate sufficiently. So we have a non-rebreather in place, flowing at 15 liters a minute. We have our OPA in place. This is great. We can do this for the first 5 minutes of this code. So as you move up to, how many compressions you got? 60. Okay, so when he moves up to about 85, or 90, he'll start counting. He'll go 85, 86, 87, 88, 89, 90. Then we'll know that we're about to cycle in and move to another compressor after his second round. We're doing it every 2 minutes, flipping back and forth. So again, for the interest of time, this is going to continue to cycle down. So we know we've got 30 seconds left, and it's going to tell us to start CPR. So we'll go ahead and continue CPR. While he's doing that, this is an EMT class. This is our basic procedures, right, guys? What does this look like when we integrate with our paramedics and with the advanced part? Well, it looks like this. So we can go ahead and bring in a Lucas device and our LifePak 15. We'll show you guys how the transition looks, okay? A couple of special circumstances to talk about. We got 15 seconds left. What if this had said no shock advised? What would we have done? If we'd only done 2 minutes of CPR, at that time we're gonna go ahead and just check a pulse, make sure there's not a pulse back. The reason it said shock advised is he was in 1 of 2 rhythms. He was in either VFib or VTAC. Okay, here we go.
Analyzing now.
And it's going to assess for those 2 rhythms once again.
Shock advised.
This will be our second shock, which means I'm compressing this time when the shock's been delivered.
Stand clear. Push to shock.
All right, right back into compressions. We're 1 and 2 and 3 and 4.
Start CPR.
So I'm going to go ahead and do compressions, but I'm going to have someone else take over for me so I can talk to you guys a little bit before we make this transition. So Rojas, you can go ahead and move in and take over. You ready? Ready? All right. Off. So he's continuing compressions as compressor number 2. The reason we wanted to make sure and analyze for that rhythm is it's going to be 1 of 2 rhythms that'll shock. It'll either be the pulseless VTAC or VTAC with a pulse potentially, and VFib. The 2 we want to shock are both pulseless. There's a question you guys had for us, and that would pertain to what if this was telling you to shock, but you could feel a rapid pulse in the neck. That tells me that the patient's probably in VTAC, okay? Not essentially you know what the rhythm the patient's in, but if the patient has a pulse and the machine is telling you to shock, that is not what we want to do. That's the one time where we'd actually turn the machine off, or rather just unplug the pads. Actually, the preferred choice would be to unplug the pads. We're always going to leave the pads in place. And why that is, you'll see here in just a minute. So when the LifePak 15 is here, we can get that set up. I want to move into this roll with the LifePak 15. If you'll go ahead and grab the leads out for the paddles off this side. I want to show you guys what that transition looks like and why it's important we leave the pads in place. If you were to take the pads off, there's a chance they're not going to stick again. There's a chance that you're going to have not enough gel between you to get good conductivity. And also, you're just using a set of pads needlessly. Our pads are here. He's going to take this and take that out of there and connect it into this, which is ours. And at this point, we can now change our monitor over to paddles and allows us to start looking at the heart rhythm. And for us, we have an asystole heart rhythm. See the flat line right here, that's asystole. We talked about this in class. Systole is a squeeze, right? A means without. So asystole is without squeeze. His heart is not beating right now. In reality, what this would actually show while he was getting compressions, it would show a rate with the compressions you would see on the monitor. But every time he stopped for a rhythm check, that rate would go away and you'd see the underlying rhythm. We're able to do that off the pads that you guys put in place as EMTs. All right, the next thing we're going to do is we're going to move into the Lucas device. Let's go ahead and transition Mark back over to compressions. Y'all ready? Ready. Okay, the Lucas device, I'll come underneath. I'll put the backboard underneath. If you want to go ahead and grab the device itself and get it ready. All right, we're going to do a quick, go ahead and continue compression. All right, I got this position behind the patient. He's going to come right over the top, click it in place. Go ahead and keep doing compressions. All right, stop. Now we have a Lucas device doing compressions for us. This is pretty much where we're going to end this scenario for you guys. What we want you to see is how we go from a basic recognition, initial assessment of the patient, determining that they need to have CPR. We pulled them off the chair, got them on the floor, we could work, we had a good working area around us. We started using our pit crew method. We had 2 shocks, which is something you want to report to your incoming crew. We shocked them twice, we had 4 minutes of CPR around that. We've got the non-rebreather in place. We're at a point now where if we continue, we can go ahead and drop an eye-gel. And with the eye-gel, we go ahead and take the non-rebreather off a minute, remove the OPA. If you want to zoom in real quick, we won't get a good insertion on the mannequin, but we'll give you the gist, just simply because he's not prepped up to receive an airway. The eye gel would be lubricated. We'd get everything ready for it. And then we'd make the insertion of the eye gel. And again, this won't take, you won't be able to insert it past that. So once the eye gel is in, it would be up to the teeth right here at the black mark. We'd attach our BVM, but between the BVM and the eye gel, we would use our end title, and that will hook back to the monitor. It'll be one of the earliest indications of what's going on with the patient, whether it's getting better or getting worse. I think that's going to conclude it for the scenario. Thank you for your time.